Those are things that oftentimes are not well known prior to going into ER, that you do have this breadth and this wealth of knowledge.
Dr. Jamal Rahimi, how are you doing, my friend?
Hey, brother, how are you doing?
I am good. Founder of Suture Buddy, emergency medicine physician, dad of 2. You do it all, man. I'm excited to have you on tonight for eShadowing. Thanks for taking some time to join me tonight. Thank your kids for a little bit of time away from daddy. Let's talk about emergency medicine. I love emergency medicine. I think there's a lot of misconceptions out in the pre-med world about what emergency medicine is. Even in the medical student world, I want to start with that. The biggest misconceptions or myths out there in the emergency medicine world that students have.
I think the biggest myth and the myth that really started early on and really just kind of disseminated against within other specialties was the myth of this stupid ER doctor. I'm just the ER doctor. I'm just that. That is something that's perpetuated quite a bit throughout my. I finished medical school in like 2011 and still hearing that. Dumb ER doctors. But really in the 3 to 4 years of training you get and the amount of knowledge you have to absorb as far as different organ systems, pretty much the entire person, and really learning every other specialty's language, being able to talk to anybody, any other type of doctor in their own jargon and understand and talk cases and things like that. Those are things that oftentimes are not well known prior to going into ER, that you do have this breadth and this wealth of knowledge. And the joke is we are your second best, right? I'm not a cardiologist, but I'm the second best cardiologist. I can read AKG like nobody's business. I'm not your orthopedic surgeon, but I'm the second best orthopedic surgeon and the best one you got right now. So that's kind of that. We kind of joke about that, but it really gives you an overall aspect of medicine and understanding that there are so many specialties, so many careers in medicine, and how each one differs, and actually how they all actually just overlap.
Yeah. Now, emergency medicine is interesting. One of the common questions I like to ask on here is what is your bread and butter? I think, again, there's some misconception around what emergency medicine is. It's all blood and guts and gore because of media and television. But for you, and obviously every hospital is going to be different, but what's bread and butter where you're at?
Well, actually, blood and guts. And a lot of death, but we do good work where I'm at. But for pure numbers' sake, a third of what comes through an emergency room, 1/3 is orthopedic related. So we're talking broken bones, twisted ankles, fractures, dislocations, all of that stuff. So 1/3 of what you see is that. Only about 11% of what comes through an emergency room is considered critical care. Life or death, this person's going to die right now. But if you glean the overall, and kind of move, the 100 miles out and look down, you see that who else is going to reduce that shoulder at 3 a.m., right? So those are technically emergencies.
Yeah.
And based on definition of, we can talk about what the definition is considered of an emergency, but that's pretty. So a third is orthopedic related. About 11% is true critical care, intubating, CPR, chest tubing, that kind of stuff, and then the rest is just a mix of whatever your community hospital or your academic institution gives you. So with my facility, we just got level 3 trauma status. We're actively pursuing level 2. Which we intend to have by hopefully the end of this year, beginning of next year. We see all trauma, so level 1s. We see stabbings, shootings, but our bread and butter ICU would be the medically sick. So we're talking end-stage renal disease, emergency dialysis. We serve a population north of Houston. We're on the outskirts of Houston, and we serve a population north of Houston that they have to decide between paying rent and getting their insulin. So we do good work, but a lot of people will come on their life. Just they wait for their DKA to kick in because they know if it's not DKA, they're not going to get admitted to the hospital and they can't get their medications and get fixed up like they want to. We have a large undocumented population, so we do a lot of what we call compassionate dialysis. So a lot of them have to wait until they think they're gonna, their potassium is high enough, and so we do a lot of that medical stuff. So prior to going trauma the last few years, it was a lot of just medically sick patients. And the cool thing, I've been here 6 years in my hospital. In the first 4 years of it, or almost 5, we in the ER responded to all codes in the hospital. So the training I got was quadruple fold as a new attending and beyond, because I got to code everybody in the ICU. I got to put chest tubes in the ICU. I ran codes in CT scanners, on floors, in bathrooms. So and then once we went academic and got the residency, we kind of have to stop that and, let the ICU be the ICU and let everybody else, put their big boy pants on too. So it's been great not doing that, not having to run and get extra exercise. But the first 4 or 5 years and being a new attending, it was a lot of fun, a lot of action. So a lot of medically sick.
Nice. Talk about, you mentioned being a level 3 trauma center. Some students asking, what does that entail, and what's the difference between 1, 2, and 3 for levels of trauma centers?
It's a great question. So we'll start with level 1. So these are based on the American College of Surgeon guidelines for trauma designations. And you can have no designation up to a level 1 designation, which is your top tier. And so a level 1 designation is basically it's a quaternary care center. You have all hands on deck all the time.
Yeah.
So it doesn't matter at 5 a.m., at 2 a.m., 3 a.m. You need a neurosurgeon, you got a neurosurgeon there to do something for
in-house.
That patient.
In-house.
In-house, exactly. Yeah. Maxillofacial surgeon, you got that. If you need an ENT, you got that. You need the trauma surgeon, they're there. You're the hospital that's getting your level 1. You're getting transfers in a lot of times. You're rarely transferring out. So you're getting people as far as this is trauma goes, you're accepting a lot of traumas from smaller hospitals that are level 2s, level 3s are not leveled or undesignated, because, traumas happen everywhere, but you can't have a level 1 everywhere. So there are smaller hospitals, and their job is to hopefully have good, solid emergency room physicians and, other doctors who can stabilize the patient long enough to get them to where they need to go, which is usually a level 1 trauma center.
Yeah. I think there's a lot of misunderstanding from the pre-med world. It's like, oh, level 1 trauma center, that's where the Harvard trained doctors are. Level 3 trauma center, that's where the non-Harvard trained doctors are. But there's a lot that goes into it.
Yeah, I would, definitely don't. I wouldn't think that way, because there are people who like to work with less and do better work, with a lot less and work with their hands. And so a lot of people who have talent, we really hope they are in our community hospitals, because we need them there, because those are our first hospitals that someone's going to arrive to. And, with the gunshot wound, with the stabbing, with the heart attack, with the stroke. So it's incumbent upon that doctor to know what they're doing. And so the training, for residencies is pretty standard. So an ER doctor is going to know all the emergency room stuff, no matter where they are trained in residency in this United States. So same as with a trauma surgeon, they're going to get that where you trained or where you're working. You're going to get the same level of training, and you're going to see the same things when it comes to what you need to do to graduate.
Yeah. Awesome. I want to get into some cases and then get into some Q&A, and we'll figure out how to give away 5 of these suture buddies for students. Yeah. You ready to rock with some cases? Yeah,
the ER doc is always the most fun person to have at a dinner table, because the stories are abundant. Yeah. So we have a few cases, and I figured people would like blood and guts. So if you don't, turn your screens off. But if you do, pretty much all the cases are that.
All right.
So let's go ahead and begin.
Blood, guts. Yeah.
Students
love that.
There are 2 cases here, and then there are several others I have that are more about laceration. I do a lot of laceration teaching as well for NP students, PA students, things down here in Houston. So,
real quick before we jump into this, just standard because students always ask this question. Standard training path for emergency medicine, is it still 3-year residency, or are they switching to longer residencies now?
No. So it's 3 or 4-year residency programs,
Okay.
and really the difference in why, and this is a question, is why are there 3 and 4-year residency programs? When ER was first, in its baby stages of being a residency program, there are other programs who made it a 1+3.
Yeah.
So initially it was 1+, and then they just kind of took that, a TY transition year away and just made it into a 4. It made it easier for that program rather than trading it to a 3-year. So I think the it's like 60-40, 3-year to 4-year.
Yeah. Okay. Awesome.
Excuse me. So let's go ahead and let's have some fun with these. Ryan, if they have any questions along the way, please ask.
Yep.
These are going to be fun cases. Sorry, we'll go over that later.
One quick follow-up, just because we were talking about the training path. What are fellowship opportunities coming out of emergency medicine residency?
Great question. They're more being added every year. So residency are going to be, fellowships are going to be either a 1 or 2 year, and you can do anything from ultrasound to international medicine. You can actually do ICU medicine, critical care, which is 2 years, toxicology. So if you wanted to be a toxicologist, that's through the ER path as well. That's 2 years. There's space medicine. I'm here in Houston, and they do take ER physicians to do the NASA residency program to become.
We've had
astronauts.
one. We've had one on eShadowing.
No way. Who? Man.
Oh, what's his name? I'll tell you in 2 seconds.
Yeah. Okay, great. Because I do Wings Over Houston. I was a tent attending last year, and so I got to know a lot of those NASA. I was giddy like a little kid. It was great to be in. It was awesome stuff.
It was Dana.
There are a
Levin.
couple more as well. International medicine, I think I said already. Sports medicine is another one. So if you're really into that, so there are abundant fellowships in emergency medicine.
Yeah, Dr. Dana Levin is he's at Columbia or Sinai or something in New York, but he's down in Houston doing lots of stuff with NASA.
I'm likely have met him because I've been there a couple of years as with their Wings Over Houston program that they do.
Nice.
There's a lot of you can do general ER, which you see it all, or once you be when you're the one thing about specialties in ER, I'll tell you, and I'm very blunt about emergency medicine and just medicine in general, is you're going to go down an academic path. So you want to go into academics if you're going to do most fellowships, because they're a waste of time if you're going to go into the community. If you're going to do ultrasound, it's only going to make you a better ultrasonographer, but that year is going to be wasted because most places will not let you bill for that ultrasound that you can do at the bedside. Although we do it for diagnoses and seeing what the heck is going on with the patient. That 1 year is you're not going to be able to bill for that. Although you'll be fellowship trained, but if you're in the community, it's not going to make you more money or anything like that.
Yeah. All right. So
we will look at some lacerations and a long story on how we all started this, but this is how actually Ryan and I met as well.
We were booth buddies.
Yes. At AMSA 2019.
Yeah, so long ago. All
right, so quickly a little bit about me. So my undergrad was at UCLA, magna cum laude. Go Bruins. Medical school is UC Davis. Go Aggies. The residency I did at Northwell University Hospital, that was in New York, in Long Island. Go working my butt off, that's for sure. Attending Hood, I've been here in Houston, Texas for 6-7 years now. Affiliations, I'm associate professor of clinical science at the University of Houston School of Medicine. They are the Cougars. And then core faculty for the HCA Kingwood Emergency Medicine Residency Program. Now, wow, that's a wow. Now, let's actually talk about who I really am. All right, so non-traditional. All right, I was actually born in a refugee camp in Pakistan and came here with my mother and sister. And so very non-traditional student. I took 1 year off after high school. I went back to Afghanistan. I'm originally from Afghanistan and traveled. So I came home and did a junior college for 3 years, smartened up a little bit and was able to transfer. So I went to UCLA, spent a total of 5 years in college, and then took another year off after college. So I was 25 when I started medical school. So I will give you a story. When I was an intern at, 29, my third year resident who was graduating and becoming attending, she was 26. So
I was also 25 when I started med school.
Yeah, so it's more common than people think, and it shouldn't turn people off.
Yeah.
Why ER? We can talk about that. I'm sure people are going to ask that as well. It's a loaded question, I think, and a personal one for every person. So this is actually, we'll start here. This happened 2 days ago, maybe. And so I wanted to make this a case here. This is one of my interns, Dr. O'Leary. He got quite a surprise when we took off the EMS Splint here. So I'm going to give you a little case here. So he's actually a 38-year-old gentleman. He has no medical history. He was on a ladder in his house, on one of those high ladders, painting the ceiling. And the ladder caught from under him. He fell, landed right onto that right leg, and he couldn't walk. He actually had to crawl to the phone, call 911 for help, and paramedics brought him here. He didn't hit his head, didn't lose consciousness, that he told us, anything like that, but there was an obvious deformity going on. So when we took the splint off, I wish I actually caught his eyes in real time, because I think this was the first time he's encountered one of these. So we kind of get a close up there, and we see a open ankle fracture. Just, we can be very general right now, an open ankle fracture, right? And so that's what we see. This is kind of aligned with the x-ray now. So we're being very general, because now we have an x-ray and we're seeing there's a lot more going on, right, than just an open ankle, what we're calling an open ankle fracture.
Priyanka says, wait, is that the bone? Really?
There's a lot of bones.
Yes, that is.
So if everybody wants to join along, the middle, ankle bone and the outer ankle bone, right? So there's two big bumps. So your outer ankle bone, if you touch it, your outer ankle bone right there, that's number 1. Just a little higher up, right? So your middle ankle bone is going to be number 4, so everybody can follow along. And number 4 is what's sticking out of this guy right now, the bigger one, the tibia. So that's your tibia. You can see, right? You can see my arrow?
Yes.
Okay, great. So here's your tibia, here's your fibula. So obviously this kind of force dropping from 8 feet right onto your foot is going to cause a lot more damage. So we know that we're gonna expect more than just, there's a broken bone. So we see there's several things going on, and more than this if we want to get very technical, but we'll keep it to 4. So first thing we see is this fibula, which is not the one sticking out, is what we call comminuted. Comminuted means broken in more than one place, so 2 or more places. It's displaced, meaning it's not straight anymore. It's angulated, meaning it's at an angle, and I'm not going to measure the angle, or there it goes deeper into that. And it's the end, the distal fibular fracture. So it's the end, the distal part. If this were the proximal, it would be towards the knee, right? So these bones go, your shin bones basically go from your ankle to your knee. Secondly, we have an ankle dislocation. You see his ankles, these bones should be right up where that arrow is when you straighten them out.
Number 3 should be on top of 2.
Yes. Number 3 should be on top of 2. So this is your dislocation. And this is what's sticking out here. You see I tore the skin. And then there's a laceration to the medial ankle. Obviously, that's how it's split right open. So we have a lot of things to consider here. What do we do now? So you should have seen my intern's face. He was pretty shocked. And I said, there's only one thing that will scare me out of all of this right now. And that's number 1, pulses. The very first thing you learn is this is an injury. Yeah, the bones, don't let the bones scare you. They look bad, of course. They'll be fixed. If this guy is broken, these shattered bones are sharp. They can cut through an artery or a vein. Now, if you cut through an artery, that's harder to fix than a bone. So you're talking very, very microsurgery and again, these are very specialists, right? So if he severed an artery, he might lose that entire foot. So who cares about the bone if he bleeds out from that artery and the foot is no longer viable. So that might happen if we didn't have a vascular surgeon or, have to transfer him or something like that. So don't let the bone freak you out right off the bat. We need to know where does he have a pulse in that foot? If he doesn't, we're worried he's got a artery tear or transection, and that we need to actually kind of tell him to grin and bear it, and we're going to pull on that ankle right now.
And so just for clarification, because Isabella had a good one, right? How about nerve injuries, right? We don't necessarily care about the bone yet. It's sticking out. We can fix that. And the nerve, right? It may be damaged, whatever. But the pulses, now we're talking about, are we going to have to potentially amputate? Because if there ain't no blood flow, then the foot's going to die, right? That's what you're worried about?
Exactly. So emergency room, you have to be able to triage what's going on. And so and that's a great question, because yes, there's likely, as you see, there's not just broken bones. There's likely muscle damage, right? There's likely torn muscles. There's likely torn ligaments. There's likely torn tendons. There's likely torn nerves. So all of that. But of everything that we've talked about, the thing that would hurt this patient the most is if he severed an artery, because like you were saying, we would have to amputate that foot if it became too blue and pulseless and cold. And so you only have a certain amount of time to restore blood flow. Nerves grow back. Nerves grow back at a rate of like 0.02, if they do, not all do, but if they do, they grow back like 0.02 millimeters a week or a month. Don't quote me on that, but it is a number.
Second best neurologist here. You got to know.
There you go. I knew they grew back, so I can tell you that. So pulses. That's the only thing that's going to scare me. Thankfully, I checked his pulses, and he had pulses. So now we can rest comfortably, get this guy comfortable, work it up with an X-ray, because if he didn't have pulses, we don't have time for an X-ray.
Yep.
We don't have time to get him a lot of pain medications either. And I've had to do that a few times. But in the end, they're very appreciative because it hurt like heck. But guess what? They still have a foot. So it's one of those things that you really have to, and unfortunately, it doesn't happen very often. But if you've done this long enough, you will encounter this no matter where you are, at a level 1 trauma center, at a non-level any trauma center, right? This is a guy painting. So this can happen anywhere. So call an adult is my ED workup. You gotta ask, what are we gonna do now? And then, or how are we gonna put this guy under, right? So that's another thing you have to think about. And then it's your time to shine, because guess what? If I pick up the phone and call an orthopedic surgeon, do you know what the first thing he or she is going to say is, have you attempted reduction? Basically, no matter what, I have to try first. And if I fail at it, they might come in, or just we'll admit to go to the OR, or they'll come down and be able to help out. If I haven't seen an orthopedic surgeon in my down in my emergency room in 6 years.
Define reduction.
So it's reduction and whatever and so this guy's going to stay in the hospital. That he's going to be admitted for surgery. So my job is temporary. My job is to get this looking pretty, get it lined up, make sure there's no vascular injuries, clean up any debris, all that stuff, get it nice, put him in a splint, and get him ready for surgery in the morning. And then because the orthopedic surgeon is going to have to fix this in real fashion. He's going to need plates, he's going to need screws, he's probably going to need a lot more than that as well.
Yep.
So this is true emergency medicine. You're fixing it, you're saving limbs, you're saving lives, and then you move on to the next one. So here are if you look there, the stars. So DP means dorsalis pedis. Dorsalis meaning the dorsum, which is this part of your foot. Like if you look at your hand, the back of your hand is the dorsum of your hand, and the front of your hand, the palmar aspect is the palm of your hand. So dorsalis pedis, because of pedal artery. So that's where this artery is, and that's what you're going to have to feel. Also, if you look here, The PT is posterior tibial artery. So behind the tibia, which is this bone sticking out right here, right? So does he have distal pulses? Meaning, because if this is severed, we still have to make sure that there's a pulse here that, that's the thought process, right? So the most distal one. So on this distal pulse, the DP pulse, the dorsalis pedis, he had a pulse. So my anxiety level went from 10 to 0. I didn't tell my intern that. I wanted him to squirm a little bit, but I'm sorry if I'm being mean. It's just a joke. But it's one of those things that's the first thing you do. You're trained. You know what to do. You can breathe a sigh of relief. You can get an IV. You can get him pain control correctly. And that's the biggest thing, is getting this guy pain. Imagine that was you, your mom, your dad, your brother, your sister. You want them to be comfortable.
Yep.
So here we go again. And we did sedate him. We can talk about moderate sedation. This was actually quite a difficult one. It took both of us really, really working that bone back in. But as you see here, I'm your second best orthopedist. We got all this, what I call good enough for government work. Everything straightened as straight can be. No matter what, this is all going to slip out if that cast, as you see, this line here is the cast if people are asking. So here's the cast, right? So it's temporary. It's going to be on for less than 24 hours. The orthopedic surgeon is going to come in and fix all of this, straighten it all out. But we've now mostly reduced the ankle dislocation. As you were saying, this should be 3 should be on top of 2. We've straightened this out correctly enough. And the bone is no longer protruding from the skin. It's back in. And we washed it out because that's a big deal, right? Post-operative infection. So that's another thing that I really worry about. And I want to make sure, I know they're going to clean him out too in the OR, but I want to do it too, because if I don't do it correctly, the infection is going to set in with me, right? With him starting in the emergency room and kick in a couple days later. So I have to really, really wash this out. The solution to pollution is dilution. And that's how we say it.
Lots of questions about how you actually reduce it, right? It's not just sweet talking. Like, please go back, right? A little Happy Gilmore, like, go to your home. Don't you want to go home? Right? I
actually was yelling at it at some point. It took me about 20 minutes to get that bone through the skin. It's like, oh gosh. Yes, great question. So this is a very straightforward, what we call traction, counter traction. So what we need is someone very strong to grab the thigh, right? And they're going to resist me. So I'm going to pull at the heel of the foot, and they're going to resist me. And so I actually have a model down I could show you. But basically that's it. So I'm pulling the heel of the foot. And if you look here on the left image here, what we have to do is actually pull down into the left. And then it kind of clears it's basically straightening it out. So someone's like grabbing the thigh and going one way. I grab the heel of the foot and go the other way.
Like this. Oh, you're not looking at the video. I'm sitting here with my leg. Here, close it. Look at me. Look at me.
Where are you?
go to your tab. Look at me.
There it is. Yes.
My skeleton fell apart.
Thank you for showing. Yes, that's exactly. So it is. Orthopedics is barbaric.
It is. It is not.
Bones.
Not gentle.
Hear them crack. You hear them crack back together. You feel them crack back together. So it's a lot of strength back and forth. And really, it took myself and Dr. O'Leary pulling at the heel. And one of our nurses, who was about 6'6", grabbing the thigh and pulling that way.
Yeah. And there are, I think, students, you have to remember, there are still ligaments and tendons and muscles attached, and they want to go back to where they were before. And so when you get it right, a lot of things will just pop in.
That is very true, yes. Yeah, so it's very rewarding to do something like that. And, and obviously he's got a lot more to go. He's going to have a lot of recovery to be had, but it went great. There's no limb loss, no toe loss. He'll eventually walk, once he gets fixed up there, and then maybe with a limp, but at least he still has a foot.
Yeah. Awesome.
Yeah. Yeah, you guys want to go over one more real fast?
Rachel says, LOL, me at 5'1", wanting to be an orthopedic surgeon. Talk about that. I think there's a lot of, I mean, you're an emergency medicine physician, but I'm sure you've run into your fair share
Rachel.
of smaller, petite women who are amazing orthopods.
Can I just,
let's do it.
I have a story for you.
Yeah.
All right. So this exact ankle case, the worst one I ever had is I have it in another lecture series that I present. It was even worse than this. And I was on single coverage. I was a year into attending hood, knowing what I should do was call the orthopedic. And I called the orthopedic surgeon and he said, "Oh my gosh, what are you saying? No pulse." Oh my, no, transfer, hangs up. Community hospital where no trauma designation yet. And so I said, this is the time to shine, let's do it. And so we went, and I'm trying to pull it, and everybody's helping. And Dr. Denise Ryan, if I can give a shout out to Dr. Denise Ryan, a doctor here in Houston, Texas. She is 4'11" or 4'10", and she's got about 20 years experience in the emergency room. And she comes running in. She had happened to be checking in. She was starting her shift. She comes running in, and she goes, honey, you're doing it wrong. Hold it. And she puts her hand into the ankle joint, maneuvers this bone, pulls that, and starts sweating. I look in awe. And she gets that clunk right over there. It was beautiful. And I only thanked her like forever, and I tell this story all the time because that woman saved that man's foot. It wasn't me, although I like to tell it another way every now and then, but she came running in there and she knew what to do, and it didn't even don't worry, it's work smarter, not harder. And she knew the anatomy like nobody's business. She was able to fandangle her fingers in there and do this and that and get it back. So if you're interested in orthopedic surgery, there's no problem with that.
Nice. Cool. Good story. All right. More blood and guts.
All right. Let's do one more here that I really like. This kind of gives you, and I just kind of what we do sometimes in the emergency room as far as being MacGyvers and fixing things in different ways. So this poor guy, he was working in his garage, and he had like a chain link, and the chain link was pretty heavy, and it fell, and it caught him in his nail and just kind of tried to take his nail off, but it didn't go so smoothly. And kind of like wrapped in there and pulled and tugged everything. And so right off the bat, if you look at my arrow here, you can see this nail bed laceration. So we'll talk about that too. But here you see the nails going off. He's got a really deep laceration here that's just coagulated right now. And then this is the nail bed lacerations. This is something we have to identify, because if we don't fix this with some buried and absorbable sutures, then the nail will never grow in the same and might not grow in at all over this laceration, because you have to restore the vasculature here. And nails are pretty long. It starts about right here, back, under the skin right here. So these are things that we're working with. An open tuft fracture. So what's that? The tuft fracture is the tip of the finger fracture. Usually they're closed. You jam your finger, you get it caught in a door jam or something like that, and you end up breaking the tip of the finger. That's a tuft fracture. You really hope they're closed, because then you don't have to go home with antibiotics. That's all. So if they're open, we usually will send you home with antibiotics and give a good washout. That's the biggest thing. So now we know this nail is not viable. Look how dusky it is. He came in a little late, right? So the nail is dying off. So I can't reattach the nail like back on just to put it back on, which sometimes we can. So I was like, this guy's got a nail bed laceration, so he's even more open to infection. So I'm gonna have to clean this up. So what am I gonna do about that? So here's a couple views: the lateral view and the anterior view on the right side of what's going on. And again, you can see that deep laceration, that deep cut right here in the actual meat, the nail bed right under the nail. So and here you see it like it's just ready to come off. And then actually the tip of his finger is pretty much ready to come off. So first thing I'm thinking, I got to pull this guy's nail off. This is the torture stuff, right? Like, oh, how do you, because it's still attached to the meat here, right? Yeah. To the pulp. So this is going to be painful for this guy. So we anesthetize him. We do what's called a digital block, where we stick anesthesia and numbing medication, lidocaine, which is like Novocaine when you go to the dentist, and we stick it in the finger at the base here, right up here, and it does burn for like a minute, and then the entire finger goes numb. So I can chop his finger off if I, obviously not going to, but it's that's what you do for these surgeries and lacerations and things like that. So you don't have to put this guy under anesthesia. You can just deaden the entire finger.
So let's see real quick. So lidocaine for everyone watching without epinephrine for the digital blocks. Let's see if the students know why, if they know why we do it without epinephrine.
Great.
See what they know.
And can we get the one, two, three, the 5 places, the 5 body parts not to do it on? How about that? We can get the entire group to group work that one.
Nice. I don't even know if I know the 5. So Christy Johnson says increased blood flow. No. Amir says constricts. But why constricts? A lot of people say dilate blood vessel, blood loss, lots of blood loss. They could lose the finger. Yes, Trevardo. Nice. So the 5 places. Anyone know where the 5 places are? How about you tell us the 5 places?
All right.
So just to confirm, so epinephrine, right? Very strong vasoconstrictor. You don't want to, right? We're not worried about bleeding. We are, but there's not a lot of blood there. We don't want to lose.
Pure alpha. I missed it, but yeah, someone wrote in there pure alpha. So good stuff there.
Yeah, we don't want to lose the finger from cutting off the blood supply.
Eyeballs. That's good. Wow. How are we going to get into the eyeball? That's a good one. Fingers, hands, feet, veins. Someone got genitals. There. Okay. I'm seeing all the answers. So you guys are crowdsourced. You're doing great. So places. So as Ryan was saying, there's places that are, first of all, that have decreased blood flow in general. So to give them a medication that even decreases it further by constricting isn't a good thing. And the reason, then you're going to ask, well, why are we giving epinephrine and lidocaine anyway then? The reason we do is because for what it does, it constricts blood vessels. So it keeps the lidocaine where you want it longer, rather than it just diffusing out into your tissue. So that's why it's great to do lido with epi when you can. And the 5 places you can't: ears, because cartilage, not a lot of blood flow. You're going to kill off an ear. All right. So not a lot of blood flow with cartilage. So that means nose, ears, nose, fingers, toes, and the genitals. So that's the 5 places.
Got it.
Now, do we have, now, what does he lido with epi? It's going so fast, these questions. I'm like trying
I love it. Let's get back to blood and guts.
All right, let's finish that one. There you go. Got to take the nail off. Took it off. Numbed him up. He's not having any pain right now. And that's a whole mess there. So my plan is, okay, now what am I going to do? I'm just going to wrap him with Vaseline gauze, and he's so open to infection right now, right? So after I suture him up and put his fingertip back on and fix the nail bed laceration, well, it's still open for infection. So what I did, here's me fixing the nail bed laceration, and I used the nail as a splint to avoid infection. So I put the nail back on, and I sutured the nail to the tip of his finger, and to another spot as well. And that way, this keeps what we call a splint, and it tries to keep the nail bed from being infected. After this, a bunch of Vaseline gauze. Obviously, we cleaned this, washed it again. Vaseline gauze. He got a finger splint to keep it straight, and I saw him about a week later to take the nail off.
Am I misremembering sometimes putting some like aluminum foil underneath the nail there as well?
Yeah, that can be done, and just keeping it moist is that easy as well. You can just do that.
Nice.
As long as it doesn't get too dry and it's not exposed for the first few days, because it's exposed to infection.
Awesome. Awesome cases, blood and guts. We love it. I just invited some people on to join us here on stage. We got Shane. Shane's always here. Say hello, Shane.
Hey, how's it?
Dang, how you doing?
I'm doing pretty good. So I've only had one emergency room visit in my life, and it wasn't even my emergency room visit. But my impression was that it was a minor thing, so it got handled by nurses. So I was kind of curious, how often do procedures and cases mostly get passed off or delegated to nurses, NPs, and PAs versus how often do you end up getting hands-on with procedures?
Great question. So you likely you have had to have been taking care of somebody more than just, and I don't mean more than just a nurse. My wife is a nurse, so I don't mean that. What I mean is that you have to, by an NP or PA at the very least, because they're called advanced practice providers. And so in so a nurse will see you as well, obviously, getting the IVs, giving the medications and all the other stuff, and relaying, especially if some of the providers busy with 25 other patients, relaying info back and forth if I can't come to you in time. I will give you an example of my hospital. If you see me, we have multiple nurse practitioners and physicians, so we have a great group. We're intermingled. But if you're seeing me, it's a laceration or a procedure that's too hard to do or they're not trained well enough in, like these finger, like something's falling off, rather than if it was a straightforward, I cut myself here and I need I do suture repair now maybe once every 4 months because I don't see so they do most of that stuff. By the time you see me, your chance of being admitted to the hospital is 80%. So that's the screening. That's what I mean. So they do great because we're screening out, because everybody's ER is now it's everybody's last hope. So you come and we're 24/7 all the time. We cannot turn you away. That is the law. Mm-hmm. I don't have to ask you for insurance. That's great. And so I get to take care of you. And so it's just one of those things that there's so many more people coming, which is great, but we just can't keep up with beds and everything else. And so having these advanced practice providers helps out a lot, because they're trained in a lot of this, minor emergency stuff as well. And they can do it just as good as well as I can, or anybody else.
Cool. You did mention insurance, so hopefully this is a quick follow-up question. How often do you end up talking with insurance companies to try and get somebody to cover something? And how often is it just not at all? Wow. Okay.
Zero.
Not your
Zero.
job.
We do not ask. It is regardless of your ability to pay. If you come and you have chest and you're having a heart attack, how dare we ask you for insurance, or anybody in this world? I mean, it happens in other countries, and that's awful. But yes, that's the beauty of what we do as well, is that so the ER doctor provides the most free care of any type of physician. We provide over $120,000 of free medical care per year.
Wow.
That we are not compensated for, which is fine, absolutely fine. The next number 2 is an internal medicine doctor at $12,000.
No.
So we provide. And so I love that about my specialty. I don't have to ask you for that. Now, someone's going to come in and say, do you have insurance or not? Yes, of course. I'm not, saying someone's going to come in. If you don't have it, you're still getting treated. Mm-hmm. Like you're going to get some kind of bill. I don't trust me. I don't see any of that. I promise. Don't kill me. But that's the beauty of it, is we don't have to ask for insurance.
Nice.
Awesome. Cool.
Thanks, Shane.
You so much.
Yeah, so something good for all of you to Google and learn about is something called EMTALA, EMTALA, I think is the abbreviation. Emergency
Medicine Treatment and Labor Act. Absolutely. Yeah. EMTALA, I actually gave a lecture to the group last week on it. So it was started because back what they called Skid Row, which is a place in LA where all the homeless people lived. Homeless people are people too, but they would show up to the hospital and no one's getting paid for all the sicknesses and all this stuff. And so the hospital starts paying EMS ambulance companies to drop these and discharging these patients and drop them off onto Skid Row without them being taken care of in the hospital. Yeah. That's ridiculous. It took that much press and of what the medical system was at the time to establish something that made it, where anybody can come to an emergency room and not have to worry about asking for, about insurance or this or that if they feel they have a life-threatening condition. And that's great.
Yep. Awesome. Elizabeth. Unmute. Say hello. Hi.
Hello.
Hi, Elizabeth.
So my question that I was wanting to know. So when you were showing the case with the nail, how were you able to use the nail as a splint? Like, are there some situations where you wouldn't be able to because the nail was more dead, or because it was partly attached, you could still use it as a splint, or?
It was a splint, as in not a splint like when we have a fractured bone and we splint it with like a cast or a hat, or a finger splint like the aluminum splint. This is a different type of what we call splint, and only because it's his own biology, right? It's his own nail. Like I feel like it, and I've seen this done before. It's like kind of the holistic thing. Like his body's gonna recognize that more, even though it's dying, than some foreign body being on there, which is still going to help. But everyone I've done this with, they've come back, we cut it off and we look and it's growing nice underneath and usually no infection. So any way you can cover it, but I just feel that the body recognizes that more and won't attack it as much that way, especially if you clean it off, obviously, get it all cleaned up. That's the biggest thing, is cleaning these wounds.
Yeah. The nail's already dead anyway, so it can't get more dead.
Yes.
Awesome. Anything else, Elizabeth?
No, that was...
Great job, thanks.
Great question.
Sneha. Is that how you say that?
Yes. Can you hear me?
Yep.
Hi. So I just had one question, and you kind of talked about it when you talked about case one, but as a ER doctor, up until like what point are you able to treat and diagnose the patient before you have to hand them off to their respective departments? Like, say someone comes in with chest pain.
That's great. That is a great question. So where does the ER end and the hospital begin? So let's start with chest pain. So if somebody's having a heart attack and they're having a massive heart attack, first person they're going to see is me. I'm going to give them all the emergency treatments to save their life. I'm going to give them the blood thinners. I'm going to give them the pain medication, the blood pressure medication to bring their blood pressure down. I'm the one who looks at the EKG and says, yes, this is a massive heart attack. Call the cardiologist. Cardiologist then takes it from there, goes upstairs, goes into the groin, and fixes whatever needs to be fixed. And so the blood thinners, the immediate treatment that is at first life-saving to keep the blood thin, to keep perfusion and blood flow going, I'm doing that part. The structural part now is taken over, and the other very, very serious part is taken over by the cardiologist. Same thing for a stroke. Stroke comes in, I'm the one ordering, saying this is a stroke. At my hospital, we do not call the neurologist. We call all the calls. So we say we're a comprehensive stroke center where I'm at. So as good as they get, we do all mechanical thrombectomies and other things as well. So we make the call, we give the medication, not physically give the medication, but give the order to give the medication, and then the neurologist will see them in the morning. So that's how a stroke works. Now, a trauma, they come in and they're in a massive, bad car accident. They're going to come in, hopefully we get pre-warning, and if we do, we're going to let the trauma surgeon know. Trauma surgeon is going to come in and be ready with us. And we have very distinct things that we do, so I intubate the patient. I protect the airway. If there's a chest tube that needs to, if I need to go into his chest right now and release air or release blood and put a tube in there, I'm going to do that. If the patient's been shot and in the stomach or in the belly area or somewhere internally, is bleeding internally, that's going to go to the operating room right now with the trauma surgeon. So we have these distinct roles that we're going to perform together while saving this one person. And so it's such a continuum, so we have to know the beginnings of how everything presents and how the life-threatening part is, because by the time I call that cardiologist and they come down, if I don't give those medications, they might die. If I don't intubate this person, the trauma surgeon doesn't intubate. That's not in their scope of practice. So we're a team there. So I always see ER as the beginning of this team process. And I'm very big on EMS, actually. And so I do a lot of EMS work. So I'm very big on EMS being the beginning of the medical process and us being in somewhere in the middle continuum. So we just, we don't do it all, but we do enough to stabilize them, keep them alive, so the specialist can do the rest.
Okay. Thank you.
Awesome. Thank you. All right. Before we bring on the last two, I want to get to what do you think about how we should award these 5 suture buddies?
Man, it's your call. Somebody runs my Instagram Suture Buddy website or Suture Buddy thing, so
Okay.
I don't even get involved with the daily. That's why I told you, I was like, I don't know how to do any of this.
Yeah. Okay.
But
So
can I show them what it is?
yeah, show them.
All right, guys. So, because you guys are Dr. Gray, so this is my. I've toiled over this thing. I've started my company about 3 years ago. Basically, I'll cut to the chase. I'm not here for that. But it's a suture kit that you can use over and over and over. It feels like real skin. You can continuously use it to practice all different types of every single type of laceration, cut that you would see in an emergency situation and just in a general situation. So the kit comes with a pad, and again, they're reusable. So, you have it. You can practice and practice and practice. Suture, go to YouTube, Suture Buddy, free videos, nothing charged. You will learn straight from there. I think I'm a good teacher. I like the sound of my own voice. Maybe you will too. So if you want to learn, that's what I mean. So if you want to practice, say, I don't know how to do it, go to my page, is free, and you'll learn right from there. And so the kit is the pad as well. And here, that's an open one, but here it is. It comes, and the 3 tools you'll need, which is a needle driver, and I was doing a little suturing earlier, suture pickups or forceps, and then the suture scissors as well. I won't pull them out, but those 3, and then it comes with a full box of sutures.
Nice.
As well, so you can practice and practice and practice and practice. So all of this, so however you want to give them away, I think this is great. It'll get you into, if you think you like emergency medicine or surgery or dermatology or something, that you get to do this stuff with the plastic surgery as well. So it's a lot of fun. And my 8-year-old niece did this, and I remember when we talked when we first met, and she learned how to suture at 8 because of these pads, and that's what made me really say this is it, and let's try to do this for everybody else. So you don't have to use chicken feet or not pig's feet, chicken thighs, fruit, all of that stuff anymore. And then for everybody else, I did put a discount on the website for everybody for the next 2 weeks or so. It's discount buddy, and it'll get you 15% off and free shipping.
Nice. All right, so, let's do this if you want. So we can drive some people to Instagram. Make sure you go follow the Suture Buddy. Your last post is from 19 weeks ago. What I'm going to do is right now, in the next couple minutes, I'm going to post one of your posts on my page. So go follow the Suture Buddy, and then come to Medical School HQ and leave a comment on what was your favorite part of tonight, and then we'll randomly pick some people tomorrow. Sound good?
That's great. Yes, and go to suturebuddy.com if you want to. Very easy, suturebuddy.com if you want to look at all the rest. That's fine, and I'm always available as far as ER education goes. If anybody ever, going through you and wants to ask more questions.
Nice. All right. You got time for 2 more questions here? John
Absolutely.
And Daryl? John, go ahead and ask your question. Hello.
Okay. Thanks for having me, first of all. My question is, you mentioned how, not every situation is a critical one, but say, it is one, it's life and death, or someone could lose a limb. How do you mentally adjust to that? And how are you able to make, quick decisions that can potentially save a patient's life in such dire situations?
That's a great question. for how do you live with it? You know, especially with this COVID pandemic, and I've been front line since it all started and haven't left. It's mentally trying a lot of times to tell somebody, you know, they've lost a loved one and you've done everything you can. You always try to put yourself in their shoes, and it's never a good time to do anything, you know, to give somebody that news, and it never gets easier, nor should it ever get easier. You know, if you're jaded, it gets easier, and you don't want that, especially because if you work in a busy place, you do give bad news quite often. I think 3 years of emergency medicine is more than enough to learn emergency medicine. If you drop dead, the way I teach our residents is I'm going to train you so I can put you anywhere in the world, in any position in the world, and if someone drops dead in front of you, you can save their life. So that's what an emergency medicine doctor is. So it's on a plane, in a restaurant, in a car, deliver a baby, wherever it is, you can either figure it out and MacGyver it, or you at least are good enough to know basic emergency medicine. You know CPR, you know all the ACLS, BLS, you know how to resuscitate. So that's what the residency teaches you, is how to be a good ER doctor. The rest of learning the general medicine, remember 1/3 is orthopedics, right? So learning the non-ER stuff is up to you to become that better overall doctor.
Awesome. Thank you so much.
Thanks, John.
Great question.
All right, Daryl, last but not least.
Can you hear me?
Got you.
Okay, sorry about that. Thank you. Quick question here. My question was, has it always been emergency medicine for you, or were you thinking about other stuff? You're going into med school. That's it.
So, great question. I was born in a refugee camp in Pakistan. We were displaced. My family was displaced from Afghanistan during the the Soviet-American War. And so when I was accepted to medical school, I came in wanting to be a trauma surgeon. And I was going to go. I wanted to go and go overseas, not specifically to Afghanistan, but anywhere, and work with my hands and give back. But med school really beat me up, man, and it did. And it's a toil, but in a good way. And it made me realize, hey, I can do. And emergency medicine opened my eyes. What had happened, if I can tell you the story, because I think it's a good story, is I was a third year and I was not sure if I was going to trauma or if I was going to just ER or something else. And psychiatry was still on my mind too. And I was working in the ICU, and I had just done my ER rotation. So now I'm in the ICU, and I was really like, oh my gosh, ER is so cool. I never knew it. And someone had a cardiac arrest right in front of us, and it was another team's patient. And we all ran over there, and the fellow was doing CPR, but she was doing CPR like really weirdly. And I didn't get in. So I'm very loud and proud. And I ran like knocking like to the attending. And I was like, let me go. I just finished ER. He said, go. And I jumped on the stretcher. I did CPR. We got pulses back. And I'm a medical student. We got pulses back before they brought the crash cart over. So the next week, while I was in that ICU, I walked by that guy's bed every day, and he would see me. He didn't know anything. He didn't know what happened. Nor did I ever walk to him and say, I'm the guy who saved your life. But walking by this guy every single day and saying, I just saved this guy's life. I saved this guy's life yesterday. I saved this guy's life 2 days ago. In my mind, I saved this guy's life. And it was just such a rewarding thing to know I did it, but not. And it was kind of I don't know if it was an ego thing, but he never knew I did it. And I liked that. I liked the fact that I knew I could do it, I did it, and I didn't get the recognition from him, because I don't want that. And that's a great thing, because you save someone's life. If you do it correctly, they wake up 3 days later in ICU and thank everybody else.
You're like Peter Parker.
Okay. Yes, that's okay, because that's what it takes. You know, like you have to have that. Like you don't get a lot of accolades doing what you do. You get spit on a lot, you get threatened, you get this, and every now and then you do save life. You get a hug, and that just keeps you going. You know, for more and more and more. So it is one of those things that I just love it, that we can do these things, and then they don't. You know, and so you do it for the sake of doing it. You do it because it's necessary, and you're not doing it for the attention of them or the family or that. Because a lot of times you're actually saying more bad news than like, hey, we saved them, unfortunately, because by the time, a lot of them get there, it's already too late. But yeah, that's the reason.
Okay. Thank you. I appreciate you all.
Thank you. Great question.
Thanks, Daryl. One more time for me. What is the code again? The discount code for the Suture Buddy?
Oh, I put it up there, so it should pop up. It's Buddy, Buddy.
Nice.
It'll give you 15% off, and we ship free in the United States.
Awesome. Any parting words of wisdom for those of the students that are with us right now?
I will tell you one thing for anybody. I was an undergrad, and I walked in UCLA in my last year, and I walked into the counselor's office, and I sat down and I told her, I'm thinking I want to go to medical school. She looked at me. Maybe I looked a little different then. Maybe I was a little bit more shaggy. And she just looked at me and said, you know what? Medical school's not for you. And I didn't understand why. She didn't know I was 3.82 magna cum laude at UCLA. She didn't bother to look. She didn't bother to look into my records. She just bothered to look at me. And that is one of the saddest things I can tell you. But it didn't put me off, because I knew that those are the haters, and those are the people who you look back on as what fires you up. So if there are people like that in your life that are telling you you can't do it, don't listen to them, and don't let them get you down, because later on you're going to look at them as the haters, and that's what you wanted to. So stick with it. Believe in yourself, even if nobody else does.
Love it. Thank you, my friend. Hopefully I'll see you at a conference soon enough.
Yes. Thank you, guys. It was awesome.